All right, ladies and gentlemen, this is episode 12 of the Healthcare Growth Cycle podcast. And we've got Sarjoo Patel, MD, CEO of Beam Healthcare out of Madison, Wisconsin. So a little, homage to my home state of Wisconsin. I'm now down in Columbus, Ohio, and I've had a lot of Central Ohio healthcare leaders on, but it's awesome to have someone in the cheese state that is on the podcast and working in healthcare technology. So Sarjoo, thanks so much for coming on.
Yeah, no, thanks for having me. By the way, 13 is our lucky number in the family, so I missed it by one for your podcast. It looks like it.
Okay, there it is.
That's all right.
All right, one off. So if you want to start by just giving a quick intro and a little background, I think it'd be really useful for the listeners.
Yeah, sure. So I'm Sarjoo Patel, based here in Madison, as Christian mentioned, and originally from Chicago. Background was tech before I went into healthcare for some personal reasons, and started as a hospitalist director at a local community hospital not too far from Madison, and eventually ended up starting Beam Healthcare along with a couple other companies. But in a nutshell, so we are a pre-COVID telemedicine company. I've been doing this for 10 plus years now, but taking care of more complex patients in the hospitals.
Awesome. So I would like to get into your journey a little bit from an academic standpoint. So you studied, or you started as an IT practitioner, studying information systems, and then transitioning into being a medical provider practitioner. What was that journey like? What inspired you to kind of go from IT into actual medicine?
Yeah, and so first of all, zero intention of going into healthcare when I was an undergrad. Undergrad was called OMIS, Operation Management Information Systems. That was at Northern Illinois University. And during my senior year, just had a few personal things happen. My best friend from, kindergarten passed away when he was 22 or 23 at that age after playing volleyball. Dad ended up in the ICU, and another friend also had cancer diagnosis. So everything happened like in my senior year. And I saw the impact the doctors made for my dad, along with also my friend who was going through cancer side of things. And I grew up in a healthcare family, so I knew it, but I think never really actually experienced it personally. I seen it like healthcare being provided, right? So for me, it was truly about, hey, my heart's here from a passion perspective in terms of social impact side. That's really it. And that was my reason why I was in senior year of my college. I ended up taking some science courses to start maybe looking into healthcare and, pursuing that. But it was really more of a social impact side. I'm still a business and a tech guy at the core. That is my first love and always will be.
Cool. And how many years did you practice as a medical doctor?
I still practice. So I graduated. Okay. Yeah. So
gotcha.
I graduated in 2011. I was a chief resident, done my residency, graduated in 2011, took a medical director, hospitalist director job near Madison. It was Stoughton Hospital that, they wanted, they brought me on to really design their inpatient program so we could avoid all these, transfers out of these small hospitals to big hospitals. That was the reason, and they wanted me to create a program on the inpatient side. So I was initially hired by them in 2011, and then I started Beam Healthcare, which I could tell you a story about afterwards. But long story short, I practice as a hospitalist, meaning I take care of patients on the medical floor and in the ICU at the local hospital side of things. Now,
Wow.
Primarily now, I would say I'm 80% admin and 20% clinical. Now the team's kind of taken over.
Interesting. Wow. Yeah. And I just, I've had quite a few conversations where it's so critical to have the clinical experience paired with the technological experience. And I think there's a lot of healthcare founders out there, and I think I could maybe lump myself into that, who doesn't actually have the clinical experience. So to be talking with someone that has both of those sides of the story and is still actively a practitioner in both areas makes you incredibly valuable and dangerous in the industry. So in a good way.
Dangerous, but okay. All right.
Yeah, in a good way. But no, I guess if you want to get into the backstory of Beam Healthcare a little bit and founding that, what inspired that?
Yeah. So as I mentioned, the pain point for the critical access hospital was similar to what you hear all the time, which is, hey, we're losing a lot of patients is one thing because they're a little bit more complex and uncomfortable taking care of them locally. And we just want to manage, the patients that we have the resources to manage here. I mean, that's pretty much it, right? So we designed a 24/7 hospitalist program. Someone was on site at any given time from a doctor perspective. But to be honest, it took me probably a month and a half or 2 months to realize that, yes, this is a good program, but this is not a financially viable program for a smaller institution. And we were still losing patients for specialty reasons. So we had good hospitalists maintaining, managing open ICU kind of patients, but ultimately we're still seeing a lot of these transfers. So my solution to that was, um, I think I could do this better. It wasn't rocket science. So, the goal of Beam Healthcare was, it was going to be three pillars. Number one, we were going to leverage tech to solve some of these issues, and we could get into that how. Second was we were going to leverage core team members, meaning not gig industry, just doing one shift here, one shift there. If you have vested providers who know the community and the community knows them,
Hmm.
and the inpatient side is very different, right? It's very different than you treating cough and cold. So, anyways, core team member was the second pillar. And the third pillar was operational efficiency. Sounds kind of like, why does that matter? Well, here's the thing. Beam was going to be paperless from day zero. And the reason for that was I needed my providers to have, be efficient so they have more time with the patients. Just the chart side of things that you've heard about over and over, right? We've never truly used the word burnout in our company. We don't like we provide them as much as items as possible so they're more efficient. So once again, leverage tech, leverage core team members, and operational efficiency. So this way, if the provider is efficient, well, they're going to have more time with patient. Patient's going to be happier. Patient gets better care. They also have more time for nursing staff. Yeah, team is happier, etc. So it's a kind of a ripple effect. But that was it. Not rocket science. But
Sure.
I think where Beam stood out was we executed well over the years, and thankfully we got our first. Yes, I mean I went to a bunch of board meetings to present this. And I think a lot of people didn't see it, and I get it. I mean, I get it. They were afraid of like, no, hey, is insurance going to pay for it? How is this going to work? Even half my team didn't believe in it. Like, they told me that they wouldn't continue if we did telemedicine. I said it's okay. When you're ready, you could join. And thankfully, we got our first pilot to do telenocturnist, for a year, and obviously here we are.
It was success. Yeah. And so, just from the story of, if we want to get into a little bit more about the difficulties with regional hospitals, what are some of the challenges that they face?
No, when you say regional, like are you talking about like community and rural hospitals, or
Yeah,
okay,
community and rural. Yeah.
yeah.
Yep. Excuse
Yeah,
me.
so so you have these designation of critical access hospital, CAH, right? And then you have community hospital, which don't meet that designation, but they are still, 50 beds, 60 beds, or even 100 beds at times. But let's just critical access hospitals are about 25 beds, and some community hospitals, like I said, are larger than that at times. But what you see is when they're far away at times, or they don't belong to a bigger system, they're there by themselves, right? So the number one issue is you could have the fanciest MRI, you could have all the CT scans, etc. But if you have, one provider, nursing staff, let's say, is not comfortable taking care of them, right? That's an issue. Or on the flip side, you could provide and nursing staff who are comfortable with it, but then you have no resources. So that's a lot of times MRI is a very simple thing that we see a reason people get transferred out. And when we could talk about that, like, some of these issues and what solutions that I've seen kind of work as well. But, you know, so tech at times is a limitation from a resource side.
Okay.
Staffing is at times a resource, but the specialty is a major issue, right? Like you just don't have access to all these specialists. And you see all these transfers going out, but they don't necessarily need a procedure, meaning they don't need to go to a cath lab. They just need someone to look at their chart, an input, and guide the team here, and also make sure the patient and family are in agreement with that game plan. But a lot of times, the non-procedural transfers that we see, you should be able to keep with local specialists. But how do you get local specialists, right? Like, and that's where we leverage tech to bring access to local dedicated specialists. So
Sure.
that's how we solve that part.
Okay.
But yeah, those are the similar things. And then on the revenue side of things, I think what these rural hospitals really struggle at times is, you could go in there with the best physician or nursing staff. ultimately they're clinicians. They're not there to optimize documentation from a coding perspective, right? And I think one thing healthcare does very poorly, and I think it's getting better now, which is good, is we render or try to render really good service, but we don't capture the revenue. Like hotel business does it great. You take a bottle of water, they're going to charge you for it, right? Um, So we're providing all this service, but we leave all this money on the table, which is not okay. You rendered the service, you should properly access. So this is where case management and utilization management, that's something, for example, that even we saw with our team that, hey, we could do better, right? Like our clinicians are providing good care, but man, documentation, like we're probably leaving a lot on the table here. Like the
Sure.
hospital and the clinicians have spent so much time, but you're not capturing these things. So once again, resource issue, staffing issue, sometimes tech, and I shouldn't say issue, limitations, right?
Sure.
And then the financial side of things as well. So I think these are some of the constraints that we've seen as a commonality between these rural and community hospitals.
Sure. And just from a workflow standpoint, just for context, are all of the telehealth visits for inpatient? So are patients actually taking like a visit with a specialty clinician on a phone within the hospital itself? I'm just
Yeah, so let me kind
okay.
of talk through like how it looks, right?
Sure.
So let's say you go to the emergency room, all right? You go in with a cough and fever. If it's just run at the mill kind of a pneumonia, they'll say, "Here's the antibiotic, take it. You go home, take rest for a few days." But now you're needing oxygen when you go there, and the chest X-ray doesn't look the best. They say, "Hey, we think you need to stay in the hospital for a couple days, okay, for IV antibiotics and oxygen monitoring, etc." And let's say this was middle of the night, okay, and this is at the rural hospital. Back in the day, what would happen? They would call primary care doctor over the phone, for example, and they would put in some holding orders to get you to the floor at times, right?
Okay.
And then the doctor will see you in the morning because you literally had like one or two doctors who are on like 24/7, 365, right? Like, and that's how it used to happen. But now, so what ended up happening is the the ER would page us. So let's say if I was on call that night, all right, they'll page me saying, "Hey, I have Christian with so and so in a HIPAA compliant text message." Like I get that. I log into the ER, kind of take a EHR to take a look at your chart and everything else. And then I just, hop onto my telemedicine robot, for example, on the ER side. I'm able to self drive myself to your room, right? And I could just talk to you. Just so the only difference is I'm not there, in person. I
Physically,
can't
yeah.
put my fingers on you in terms of your belly, but I could listen to your heart from remotely. I could listen to your lungs. I could look in your ear if I want to, right? We've been doing this, like I said, 10 plus years. It's just now technology is very affordable. Before, like the self-driving robot and stuff was like $100,000 plus, right? Like it's
Wow.
not that anymore. So, anyways, and that's the important piece. So that's how I see you. And then I put in an admission order, just like I would if I was there in person. I put in my whole HMP note, right?
Sure.
And get you upstairs. And then the next morning, obviously, the person who is on site physically, the doctor will see you next morning. But
Okay.
some hospitals, they don't even have a physical doctor anymore because they can't, it doesn't make sense because their census is so low. This is where I would see you on the robot again in the morning, and
Wow.
not me, like my colleague would, and they'll round on you the same way. You know, does that kind of
That
help?
really clarifies things. Did you is the on-site robot, is that something that Beam built, or are these like common third-party robots that are accessible to use in hospitals? I'm just curious.
No, it's so we've always remained tech agnostic. And the
Okay.
reason we remain tech agnostic from the get go, I mean, we have a tech stack that we like, we
Yeah.
recommend, right? But we have no financial like incentives or, that kind of stuff. We're not trying to make money on tech, right? My goal was to, hey, take away that as a bottleneck. So the good thing is Beam has volume purchasing power, right? So now the tech stack that we do like the robots that we do like, we try to say, hey, here's what it is. It's a pass through kind of a cost and whatever. But, like I said, compared to before, it doesn't cost you that much anymore. So there's just no reason of
Sure.
tech being a bottleneck. And you don't need any fancy infrastructure. You just need a secure Wi Fi, and that is it. Right. And good access points. And
Sure.
there's nothing else local tech department really has to do besides giving it access point. and
The access points. Yeah.
and then where physically the robots sits every day to
Sure.
charge.
And then when you're on that call, like, is it just taken on a like a video chat, HIPAA compliant video chat on your phone or computer, or like how does that work?
Oh, you mean when I'm doing the robot session?
Yeah, when you're doing the
Oh,
robot.
I'm on the computer. Obviously,
Gotcha.
they're seeing me on the robot because this. And the other reason for the robot also is that, and I could send you. I think we have some videos online. You could probably just take a look how it
Okay.
looks.
Yeah. Sure.
Um, but the face or the screen is larger, and why it matters. If you had a very small, let's say, mini iPad, you as a patient probably won't connect with me as good versus having like something that looks a little bit more realistic. Okay. Also, the speaker is louder in some of these things, which is important for our geriatric patients. Okay. Um, the one thing I'll tell you, so early on, that there's two, not opposition, but the questions and concerns came up. Number one, what is our blue collar community going to say about our robot coming in? Right. Second was, are the staff providers going to be okay with it? So, in my experience to date, so number one, we over planned early on to get the acceptance of the community from the get go. Community is not an issue. If anything, doctors were the issue early on for us.
Okay.
So, and I'll tell you. So, let me, I guess, if it's okay, I could give you a little like how we designed this. Okay.
Sure.
So
Yep.
in residency, I remember my attending, they would take us, he would take us to nursing home, for example, and he would say, you go see patient XYZ. You could go talk to the patient. You cannot open up their EHR. You cannot do a physical exam. You come back and give me your top 3 diagnoses. And we're like, what's happening here? Like, we didn't know what he was trying to get to. So we did that exercise. And what he showed me was the value of um, the importance and value of, I guess, the conversation with the patient, because the patient will give you the diagnosis majority of the time. When you have time to really ask the right questions, and then not even right questions, open it up for the patient to give you the information. They'll tell you if this was acute or chronic, if they have local or system, symptoms. That should be enough for a
Sure.
doctor to now get an idea of what it could be. And guess what? Now you have labs, CT scans, other people's notes, and then you could even further like, okay, CT shows this, so yes, this is probably the diagnosis now, right? So you have all
Sure.
this supportive other thing, and lastly, you could do a physical exam, right? So that is the most important piece in the art of medicine is the interview. Everything else is a tool to paint that whole picture together, right?
Sure.
And I think that's what's forgotten when someone just reactively says, oh man, like it's a robot. No, and plus now, like post COVID, people do video chats all day, every day, right? Like,
Sure.
so it's not an issue. So I want to make sure that that's not lost,
Yeah.
that the interview is the most important piece. And patients also need to feel heard, you
Yeah.
know?
Has
Uh,
AI helped at all with the interview process? Is that a lot of hype? Is that a lot of utility? Like, what is your experience with that? I just have to bring it up.
So I would say a lot of the community hospitals haven't necessarily implemented, like, but if you talk about some of the other larger organizations, like things they're looking into is like even coming for you before you get to your urgent care visit, do an intake before you even hit the door over there or ER visit or whatever, right? Like obviously if you're not emergent, you're able to talk kind of thing. But if you're making a trip over there, you could do an intake beforehand so you don't have to wait around. And by the time you get there, they'll have a lot of this intake questions done, and AI is able to play a role in that,
Sure.
right? So I would say critical access hospitals and stuff, they don't use it as much.
Okay.
Now,
It makes sense.
what is helpful is the ambient scribe, which is probably the easiest thing for AI to get into, right?
Sure.
What it helps is now I could really talk to you. I don't necessarily have to take even notes, right, or remember everything. And the ambient AI does a very good job of capturing the conversations. And I've gone back to it a lot of times, like, oh man, I don't remember him or her saying that, but okay, like good to know. Like I
Wow.
did not remember that.
Yeah.
So that to me has been huge. And then yeah, scribing our notes from a patient care perspective is just making more expedited from that perspective. And also when you think about value-based items, et cetera,
Yeah, let's get
scribing
into that a
helps that.
little bit. Yeah,
Yeah.
so how has value-based care been a part of telemedicine?
So inpatient telemedicine, like I said, that's where we started, right? And by the way, since we started the telehospitals, then we did inpatient specialty consults, but eventually the specialty consults took off on the outpatient side where we do teleclinics,
Okay.
right? So that's obviously two different things. Um, but purely on the inpatient side, the value-based care, like you and I were talking earlier, that's not necessarily a new concept. It's just now they're really trying to hone in on it. I mean, this is like pre-residency or during residency, they've been talking about it. So almost it seems like, okay, right now the quality metrics is this, or tomorrow the quality metrics may change. But hopefully the whole concept is changing where you try to keep people out of the hospital, right? Like that's the goal. Eventually, what ends up happening is the hope is, first of all, from the value-based care perspective, that primary care are doing more preventative items and patients get access to more preventative stuff without all these co-pays and all these kind of things, right? Like which hinders people actually doing preventive care. But that being said, like inpatient, that is really meant for the sicker folks, right? Who really need it.
Yeah.
And that's what it's for. And what are the quality metrics or value-based care? I don't think necessarily it's one thing. It just changes pretty often. But it's like, for example, like you have a sepsis metrics that you're following, or you could have DTE prophylaxis and those kind of, to make sure people don't get blood clots. So these are some standard metrics that have been around for many years. Those will always remain. And so what we try to do, how do we try to attain those is through optimizing the EHR order sets. That's no different telemedicine or on-site, like that's what you have to do. So really nothing majorly different, I would say, if you're practicing a telemedicine inpatient program or outpatient, or on-site program from a
Sure.
quality
And
side.
sorry, what are EHR order sets? Like a sales order, or
Oh, I'm
what do you mean
sorry.
by that?
So when I was, let's say I'm admitting you for pneumonia, right? And let's say your white count was very high, your oxygen was low, and your heart rate was fast. We kind of look at this sepsis criterion. Is this patient just
Got it.
has a mild infection or has that like a severe infection? If
Okay.
that being said, I'll go to the EHR, I'll write in sepsis, for example, and it'll bring up this admission order set because you kind of meet this criteria. So I just have to, a lot of things are pre-checked already. So this
Sure.
way, how much fluid you get, the types of antibiotics you get, etc. It's not
Yeah.
necessarily cookbook medicine, but it is evidence-based kind of platform, right?
Yeah.
So everyone kind of practices in the right way. So those things have been in place in it for a while. The problem is, I
Sure.
would say, some EHRs are better than others, right?
Okay. And so I was going to ask, does Beam Healthcare work with a plethora of different EHRs?
Yeah. So this is where like theory meets practicality. Like as a tech guy, like early on, I'm like, hey, there's HL7 and all these things. I could do integration and they would be so much easier. We could manage so many other hospitals and with just a unified way of doing this for our providers. And it was nothing but chaos, you know? So, and a couple of reasons. Number one was we actually put more responsibilities to our clients. Like, oh, you got to do all of this, right? The tech, and as I mentioned, like their tech teams are smaller. Sometimes they have to then go to outside consultants, or they have to go to their bigger systems that they work with.
Right.
And making these integrations, this didn't make sense. Second, providers weren't actually getting all the information at times, right? Even if we had the integration in place. And even if everything was coming in, it wasn't coming in as parsed data in a really good organized format. Right. So like, great, you gave me everything, but you gave me 100 pages of things. So what do you want me to do? Like, you want me to read
Right.
100 pages? So I
Yeah.
think, this is where we did that for a while. Like, okay, lesson learned, not the right time yet. Right. So we took that out. So we go directly into each hospital's EHR. It's actually faster. But so here's our step. We have the providers, we have the AI scribe, we also have human scribes. Because the last mile, AI scribe is not there for the last mile. Like it is not good enough to actually finalize your note at 99%. AI,
Wow.
I think scribe takes it maybe a 95%. Our
Okay.
human scribes know us, they know our quality metrics or financial things that we are trying to also attain, you know,
More
our
context.
Yeah, more context. And
Yep.
they know how we write,
Yep.
etc. They help finishes. So by the time I touch the note now, I would say it's 98% done because I've given everything. Either the AI scribe's given everything, already put everything together. I give additional information to my human scribes, my team members, right?
Yeah.
And I think this is where healthcare needs to leverage team and tools properly. You know, once
I
again,
like that.
it's not a burnout issue, it's a productivity issue, right? Like if your productivity is lower than what you're capable of doing, truly, like when I say productivity, I'm not talking about RVUs. I'm like what I'm able to do as a clinician, right? Like I saw, you know, my dad and them like in India, like take care of 60 patients per day. Like they didn't have a choice. Like, but they also didn't have to write 2-page bloated notes,
Mhm.
right? They had to do what was needed. But it was common sense medicine, right? Even back in the day, here, it was common sense medicine. So while we can't get away with the two-liner notes here, well, maybe we could do something equivalent where the time I'm committing now is that just a little bit more, but I have all this team that's helping me execute, right? So now I have more time for my patients. And that's the same goes for the nursing staff. Like our tele RT, for example. I have ambient scribes from them. It's not just doctors that should have it. Like, everyone needs it.
Yeah. No, that makes a lot of sense. So moving on from more of the technical inner workings of telemedicine, the actual workflows, and by the way, I greatly appreciate your insight on the actual hands-on workflows within even just interfacing the EHRs as a practitioner clinician. I think it just gives the listeners and myself, maybe selfishly myself,
Yeah.
a more clear picture of the entire workflow end to end. But now I want to get on to the business growth of Beam Healthcare a little bit more. What would you say is one of the biggest difficulties in scaling a healthcare technology company?
Yeah. So, Beam is more of technically designated as a tech-enabled service business, right?
Okay.
Meaning we're leveraging tech to provide a service, right? So we're not necessarily a tech company because it's not our robots or software kind of thing, but it's a service that's you leveraging tech. That's how we started. And we've done it very slow over the years, right? And it was bootstrapped. And for me, first of all, in order to make sense to scale, tech needed to be affordable was one, right? Um, COVID obviously made that happen. Software and hardware is affordable because much more competition, right? Because everyone saw the value. So I think that took care of the technical infrastructure issue now, right? That anyone could afford it. Doesn't matter how big or small you are, right? Um, Even the fanciest stuff doesn't cost as much. So I would say you put that away. Now, the other piece in all of this is what we've seen and we've learned as well is going back to our earlier conversation, like, when we started, it was about telehospitalists, right? Like, hey, we are core group, and this is what we're providing so you could keep your complex patients locally. And Beam's always been more of a premium telemedicine company. So we've never gone down, like post COVID, I should mention what also happened was Gold Rush happened. So everyone opened up telemedicine, right? Like, which is fine. Like, hey, there's an opportunity, go for it, right? And I told the team that one thing we would not do is we would not, number one, compete on price, right? Because we knew who we are in terms of, once again, premium telemedicine side, but the goal is the best quality care inpatient and outpatient side, right? And to be honest, that's why post COVID, like Mayo chose us to do a telerheumatology clinic for them, right? To support Rochester, to take burden off them. We were doing 40 hours of telerheumatology clinic for them, right? So winning people over on the quality aspect, we were certified. I mean, we were accredited by the Joint Commission from the get-go. All of our programs were. So once again, technology hurdle taken care of post-COVID. Quality hurdle, reputation, we've earned it. Hopefully, I think by this time, right? So I think we could put that aside. Staffing side, we've never had issues staffing from our telemedicine perspective, right? So that was also not, I think, purely based on reputation and how we've done it. And I'll give you some history on that. Like before I started the company, I called a bunch of owners of hospitalist groups in other states. And I just called them randomly. I'm like, hey, I'm starting a new company. I'm not in competition with you, but I want to learn how you started the company, what you did from a team perspective, etc. I had some really good conversations. The one thing everyone kept going back on was, hey, financially, this is, how you design your fringe benefits, all these other things, because we're a service business. They basically told me how to save money, and that's never made sense to me. I'm like, employee retention is more important to me versus the micro cost savings here, especially if we're talking about longevity. So, and the reason I bring that up is we try to take care of our team members, and that's automatically translated into longevity. And some people have been with me for 10 plus years, you know, and our turnover rate, I don't know the exact one, but it's very low, right? From our perspective. And we have a core group that does a lot more than versus having shift industry kind of a thing. Like our one full-time could do as much as work as 15, some part-time shift
Wow.
gig industry side of things, right? So that's the thought process. So
Investing in
staffing,
your
I think
people.
bottleneck is, yeah, staffing bottleneck gone. So now the only piece that's left is for the client side, right? What makes sense? And what we figured out is Beam does not need to be the hospitalist provider every time. Like we could support their primary care who's rounding or their nurse practitioner who's rounding in the hospital or their hospitalist team through our case management and our utilization management physicians like the tele, right? And then the tele specialties. Like we could support them so we avoid all those things that we talked about, right? So they could avoid transfers and capture more uh, from a revenue perspective from the services rendered. So basically, it's a
Sure.
framework we're giving
Wow.
them for them to
Yeah.
succeed. Because a lot of times, like, they can't afford, like, let's say being served. They don't have to, though. It doesn't even make sense. Like, it actually doesn't make sense. We may not be the best partner on the hospital side, right? But this
Sure.
framework, that's an easy thing to help.
Yeah. Thank you for that breakdown. That was really, really informational. So I appreciate it. Um, I guess just the last thing, we're coming up on time here, Sarju. What would be one piece of advice as a healthcare company leader, CEO, when leading a large team?
Um, I'm still figuring it out. I would say communication is key. Although what we've can I guess there's not a simple answer. I don't have a
Uh,
simple answer. Okay.
that's right.
But I will tell you the one thing I went wrong at is, and this is not just for healthcare, but any companies, right? I have my other SaaS company, et cetera. But like at times when you're early on, when you're starting a company, you're just like, oh man, someone wants to actually join my company. I'm thankful. And you start building a program around them, right? Or even if you're your first or second client, you build the product or service just only around them. But then you lose the big picture that ultimately the things you should be designing, right? Uh, so you should design a program around a team member. The team member should be supporting the big picture, right? And I think sometimes when you give into that, you don't make the right decision. So one thing we've done is we do this thing called like culture index, for example, that we've done where everyone takes an assessment. So we have some objective idea on like how they function versus what the role we have, because we want to make sure that that's the right seat for them and it's also a right match for us for from a team and client perspective.
Yeah.
That's been important. And other than that,
Wow.
I mean, I would say every site has a director and lead person for our client. So we need accountability. And so this way we're not just a vendor just clocking in and clocking out. We want to do monthly meetings with you. We have business, intelligence, data analytics, like dashboard for every client,
That's
you know?
awesome.
Yeah.
Yeah. Um, what are typically the sources for those dashboards? Just curious from a BI perspective. Is it the EHR for each client, or you guys do data warehousing for them? Like, what does that arm of your company look like?
So yeah, so here's also like where like theory versus practicality. Back in the day when I was first designing it, that was what you said, right? Like, hey, let's leverage EHRs, everything, run reports, extract data, and make sense of it.
Right.
And then what we saw is a lot of the smaller hospitals, they don't have a dedicated informatics, they don't have the right rights, they don't know how to actually do it, or they just don't have the infrastructure. And once again, we were putting more ownership on them and responsibility. So we just created simple spreadsheets. Say every month, you just got to fill in this core data. That is it. Nothing else, right? And that's been insightful, at least for us.
Yeah.
But that's thing that's, and now with AI, like Google spreadsheets good enough. Like you don't need any
Isn't
fancy
that?
tool.
Yeah.
You don't
We're
need any
never
fancy tool.
escaping spreadsheets. As much as like IT practitioners get excited about the tools, it really comes back to spreadsheets, I feel like.
I
Um,
know.
well, this has been awesome. So I'd just like to give you the floor, Sarjoo. Where can people reach you if they want to get in touch with you and plug any of upcoming things that you've got going on? The floor is yours.
No, thanks for having me. I mean, probably the easiest place to find me is just on LinkedIn. Find me there. I'm highly focused on serving the underdogs, I would say the rural community hospitals and independent providers, if that's through Beam or other company ops, but everything's focused on either clinical operations or business operations. But that's who we focused on, small to medium-sized businesses. That's it.
Awesome.
And we do have, I should say, we do have a nonprofit called Beam Up Charity. So going back to the whole social impact side, the whole reason I joined, the field of medicine, we were able to make it come true. And post-COVID, went live with Beam Up and provided telemedicine or clinical services to 4+ orphanages in Tijuana, Mexico, and supported patients in Papua New Guinea. And we're just about to go live now in Kenya in a high school, provide them access to tech and education, access to education and healthcare.
Fantastic.
Yeah.
All right. Well, thanks so much for coming on. And ladies and gentlemen, this is episode 12 of the Healthcare Growth Cycle podcast. We'll see you on the next episode. Thank you.
Thank you.